Okay, it's 12 o'clock. Welcome, everyone. I'm Stephanie Aiden, Executive Director of AIA Spokane, and we have a big group joining us, over 50 people. So thank you so much to all of you for coming in and joining us on your lunch hour. This is going to be a great topic. It certainly fits our theme for Architecture Month of Resilience in Architecture. Our topic today is being presented by Trinity NAC, a recent merger between two companies on the resilience of healthcare. And I need to apologize ahead of time to say that unfortunately we are not offering any AIA credit today. We had some issues with getting it approved for HSW that took far longer than any of us would have realized. And so unfortunately that won't happen, but the great news is we have a great topic and I think you'll learn a lot today. So with that, I want to go ahead and thank CSI Spokane. They are our sponsor for our participation fun factor for Architecture Month. They have donated $50 gift cards to the Spokane that are good for the Spokane dining scene, and we will be giving away one of those at the end of every webinar, today included. So stay tuned for that at the end of the webinar. We also have a participation award. So those of you that attend the most sessions throughout Architecture Month, the top 10 will win a $50 gift card to a local Spokane restaurant as well, to be announced at the end of the month. So thanks again for joining us. I'm going to go ahead and turn it over to Georgia Harder, who is with NAC Architecture. She's also our president-elect and chairman in organizing Architecture Month this year. So appreciated all of her efforts, and it's been fun working with her this month. And I'll turn it over to her and let her present our speaker, Andrew.
Hi, my name is Georgia Harder, and Stephanie did a great job introducing me. And I wanted to thank all of our board members, our committee, and everyone extra that's attending, and our guest speakers and all of our members. But to go back to the original theme of Architecture Month, we were looking at the positive changes and new perspectives after COVID-19, or we're still in COVID-19, but and the obvious subject matter that we thought was relevant was certainly healthcare. And then that's when I went to the expert at our own firm, Andrew Van Loor. And just a little backstory, in 2020, NAC merged with Trinity. They are a firm based out of Columbus, Ohio. They are a nationally acclaimed healthcare analytics, planning, and a design firm. And Andrew is not only a principal here at NAC, but he is an integral leader here. And he is a powerhouse in when it comes to large and complex healthcare projects. And so I'd like to turn it over to him. I'd also like to encourage participation. I know it's hard to get undivided attention on Zoom, but if you could please submit your questions as they come in, we would really like to get some feedback from you guys. So submit with the Q&A button or with the chat, and I'll be monitoring those. So Andrew, you take it away.
Great. I'm going to, and Stephanie, I think maybe you need to stop sharing.
Okay, I can do that.
Great, thanks. I will share my screen here. Is everybody able to see the COVID-19 moving forward? Is that showing up, Stephanie?
Yes, it is.
Okay, great.
Live, so.
Welcome. Okay, well, thank you, Georgia and Stephanie. That was a very kind introduction. And I appreciate, Stephanie, all your tremendous help preparing the other day, today, making sure that, Zoom meetings go well. It always seems like there's the inevitable link or echo issue that we've been really able to avoid. So really thank you for all your help. I'm really grateful to be a part of, or been asked to be part of, Architecture Month with AIA Spokane. As Georgia said, I'm located in Columbus, Ohio. And it's been great to be part of the new part of the NAC family. I've been able to visit the West Coast almost every day virtually, which today of all days, which we got snow in Columbus this morning, was be really nice to be on the West Coast. So just longing for that. But maybe one of the most immediate benefits of having ties to Spokane was being able to root for Gonzaga during March Madness, because our Buckeyes certainly suffered pretty hard in this tournament. So I know nobody feels bad for us Buckeye fans, but we'll certainly get them next year. So this is just looking at COVID-19 moving forward. But before we begin, I really just wanted to start off with acknowledging how this pandemic and COVID-19 has really touched and affected all our lives. I certainly know it did mine. However, though I'm sure, like the rest of many of you, I'm also ready to, as the title says, continue moving forward. And that's probably just my optimism in trying to find whatever moving forward means. I also understand that we're not out of the woods yet. Many places around the world are still seeing increases in cases. And while I do hope that this presentation helps organize and quantify some of the facts and figures around the pandemic, as well as information on some of the trends or ideas we may see taking more hold in healthcare moving forward, it certainly doesn't begin to quantify the amount of healing and recovery that needs to happen on a personal level for our country and really for the rest of the world. So I just personally wanted to share my gratitude for healthcare workers. If you know any frontline workers and those supporting recovery efforts, just a huge thank you. Our thoughts are certainly with everybody that's involved in that process. So first, I just think it's important to set context. And while I know many of us are familiar with the background on COVID, I just want to take the time at the beginning here to set up the discussion by looking at the start of the pandemic and where we are now. Additionally, I think it's also important to begin by looking at some of the key impacts or most dramatic impacts the pandemic has had and some of those initial reactions that occurred during the onset in some specific areas of healthcare in hopes that when we talk about what may be occurring as we move forward, we understand why some of those things we reacted with might be more important, or why some of those things we did during the pandemic might be able to stick around with us and progress ideas that maybe have been around for a little while, but have really been thrusted forward out of necessity because of the pandemic. So we're officially in our third year of COVID as things began late 2019 in China and really took off over the next 2.5, 3 months in the United States. The World Health Organization, WHO, was put front and center as an organization that everybody became really familiar with as they started to have daily press briefings and organized releasing daily situational reports, which really from the onset was organizing a tremendous amount of information that was being collected and proved important later on and throughout all this whole process of being able to try to understand the dynamics of all this. Officially, the pandemic was declared on March 11, 2020 by the WHO with really a call to act. We shortly thereafter all became introduced to terms and became familiar with things like social distancing, essential workers, flatten the curve, terms that as a society, I don't think we ever really understood or use, but are now fixated with us as a result of all of this. So toward the middle of the March is when really some of the most dramatic things started to happen with the closing of schools, restaurants, and businesses. I think officially Ohio went sometime around March 12th, maybe to align with spring breaks. I think I hope I remember this, but our office went remote March 18th with sort of an attitude of we'll be back soon. And here we are, April 21st, still working remotely. A year later, over a year later, the truth is very evident just how infectious and really deadly the virus has been. From the time I started to pull this presentation together, these numbers have continued to increase, not at some of the rates we've seen in the past, but the numbers are current as of Tuesday from the CDC COVID tracker, which the graph on the right just shows a daily count, which is really truly amazing that they've been tracking it that closely over that long of time. However, in the spirit of moving forward, there is obviously the implementation of vaccinations, which are right now at the count that they are reporting 212 million doses administered, which account for 65% of 65 and older United States citizens, 33% of 18 and older, and approximately 25% of the United States population. So these vaccination studies were some of the largest in history. I think typically sometime maybe there's around 5,000 participants. There were over 30,000 participants in both Moderna and Pfizer BioNTech vaccination studies. So just getting into some of the severity of the impact on all these reactions and shutting down and stay-at-home orders on the market. From the beginning of the Q1 to Q2 in 2019, the GDP dropped 33%. So the United States economy effectively reduced by a third. It was a huge drop. The pandemic's impact was projected to have a shadow on the GDP with revised projections through 2030 of $8 trillion less from Q1 to Q2. So it's going to be something that hangs around with us for a little while here. The decrease in the GDP obviously resulted in job loss. We went from historic low unemployment, 3.5% to 14.8% in April, and are currently starting to flatten and level back out to 6%, which since 2010 has been about the average. So things are certainly starting to come back. Now, healthcare specifically, which CMS says accounts for about 17% of the US GDP, lost an estimated $323 billion in 2020. The American Hospital Association estimated that between March and June alone, hospitals lost around $202 billion and would continue to lose the rest, $121 billion over the remainder of the year. The largest contributor was reduced patient volumes and cancellation of elective procedures, which was about $17 billion per month. Additionally, the Physicians Foundation has estimated that approximately by 2021, approximately 24,000 primary care physician offices could close due to lack of patient volumes, really resulting in people not being able to receive the care they need, further burdening the health system as we continue moving forward with people that might not be getting the care or preventative measures they need. So the human toll, right? So what has this really done on us? And so from a perspective of CDC and Kaiser Foundation family polls, 40 to 50% of people during the pandemic missed or delayed care. Doctors were faced with their ethical obligation to do no harm in determining if it was safe for patients to come and see them. With approximately 45% of the population with higher risk of contracting complications from COVID due to cardiovascular disease, diabetes, respiratory disease, hypertension, or cancer, ED visits began to fall, which really caused concern that people weren't going and seeking care for the things that they needed to. However, as social isolation and economic loss increased during that time and ED visits dropped, there was an increase in visits to the ED around mental health. A recent CDC study assessing the impact of COVID on adults in the US found 41% of respondents acknowledging adverse mental or behavioral health conditions, with 31% experienced symptoms of anxiety or depression, 26% experienced trauma or stressor-related disorder symptoms, 13% started or increased substance abuse, and 11% seriously considered suicide in the last 30 days. So these were huge impacts on people's mental health, as well as additionally increases in abuse or domestic violence. These were about 2 to 3 times higher than the same numbers reported in 2018 and 2019. So just tremendous human toll on the public as well as healthcare personnel. So this was highly publicized. There was great stress and burnout that healthcare workers were going through as they were exposed to staffing shortages, fatigue, burnout, and now are experiencing all of the post-traumatic stress that comes with having been through having to deal with all of this. So our health system is highly regulated, and anyone in healthcare design or operations knows the letter CMS. They regulate the procedures for getting reimbursed for Medicare and Medicaid. And with all the mounting pressure on the healthcare system caused by COVID, CMS had to respond, and it did so with special waivers 1135. These can only be utilized in a state of national emergency declared by the President and Health and Human Services Secretary. The purpose of these waivers allows for reimbursement during an emergency or disaster, even if providers can't comply with certain requirements that it would under normal circumstances, and it wouldn't prohibit them from being reimbursed. So extremely important that CMS started to get rid of some of the red tape and loosen things up here so that the system really just didn't collapse financially. In February 2020, CMS released what they called the blanket waivers documents, about 44 pages focused on telehealth, facility surge capacity, patient care spaces, home health, and staffing, trying to loosen up the regulation around all of these things so that care could be provided in more flexible settings and respond to people needing to stay at home, but still receive care while also supporting the healthcare providers with proper reimbursement. So telehealth is a big one that obviously skyrocketed, and we'll talk about some of that, but facility surge capacity. So there's a lot of regulations around how much space patients need, what type of care setting and comfort they need in spaces. Those were loosened or taken down a bit so that they could, double up people in rooms if needed. Home health care, discharge planning, it was promoted more to be able to comply or to be able to discharge patients to a home health care setting. And staffing, they extended licensing requirements and changed some ratios of staffing in rural health clinics and federally qualified healthcare facilities so that they could meet the demands should they see staffing shortages or increased patients volumes for COVID. So telehealth was a one term that if it was said more as a reaction to COVID, this might be one of the top ones. A few quick facts, just here are some numbers that were found on the reaction to it. 60% reduction in ambulatory visits were postponed. Some moved to virtual, others canceled, really out of fear from both patients and doctors, just not wanting to congregate in the office. In approximately 2019, 11% of visits were virtual, accounted for about $3 billion of the industry. After the onset of the pandemic in April, telehealth visits spiked to about 46% of visits, accounting for about a 35% increase in visits, virtual visits. As the CDC tracks some of these things, 95% of reporting facilities to the CDC used telehealth during the pandemic, as compared to the numbers that they had compiled in 2019, that 46% of facilities were only telehealth ready. They weren't even necessarily using it. So it went from 46% said, sure, we're ready, we can do it, to 95% actually reporting that they were going to use it. This was a huge effort by a lot of healthcare systems to maintain contact with their patients. So nursing homes really became a ground zero for the pandemic. Assisted living facilities and skilled nursing facilities really have been a long underserved portion of the healthcare system. And there are many, many factors and challenges as to why this became prominent throughout this pandemic. And really, the image on the right became one of probably the most publicized images of people needing to separate or not being able to see loved ones or ones that they're caring for in that setting. So biggest reaction here was they cut off all visitation. They didn't want to expose, as community spread was increasing, they didn't want to expose at-risk or higher risk patients to that community spread. As a result, an already struggling industry lost $15 billion in revenue because of decreased admissions or patients. And a lot of the contributing factors we see here were across the board, but this was the highest risk population. The setup for reimbursement for some of these facilities still required patients to go to hospitals to receive care. So they were exposed to transfers and different patient populations that could have made them sick. Resident sharing room and a lot of different understaffing and staff stressors that made things a lot worse for them. So hospitals, required by many local governments to suspend elective procedures, which is really the highest revenue stream, one of the highest revenue streams for many organizations. And this was done in an effort not just to protect patients that could become more vulnerable to infection because of their procedure, but also to ration PPE supply shortage, which was really a huge factor at the beginning of the pandemic. We've seen tours lately where they've got them stockpiled now. So this is something that they're still preparing for in terms of need for PPE. One of the biggest concerns became protecting critical care beds, which also became a significant metric in measuring how communities, was also became a significant metric in many communities to determine the impact or threat level that COVID was having in that area. So coupled with shortage in ICU bed was also the availability of critical equipment such as ventilators, PPE, and blood shortages. All of those things started to see a decline due to increased patients, but also people not being able to go out and donate. Hospitals became a scary place for people. 43% from a Kaiser Family Foundation poll reported they were scared of going to the hospital for fear of contracting COVID-19. Families were dealing with a ton of anguish of not being able to visit their loved ones as visitation rates locked up and became extremely limited. Many hospitals scrambled to convert normal units to makeshift COVID units with negative pressure, temporary barriers, and cut off cross traffic. And we can see in the background here, as a concern for surge capacity, many facilities were set up in local community public facilities. This image in the background is the Columbus Convention Center. These were the surge capacity. So the one behind us here was set up in Columbus, was about 1,200 beds or could accommodate 1,200 patients, not necessarily for the need to treat people with COVID, but for any type of overflow capacity that hospitals may need. There wasn't actually any patients seen in these, and that was kind of a trend around various different states. So of the ones set up or reported to the Army Corps of Engineers, which accounted for about 17 locations in 12 states, about 14,000 beds, there was about a total of 1,200 patients treated in them. So tons of concern around this area that didn't really come to full fruition in terms of need. A lot of it was due because in these settings, care is just really challenging. Not to mention that they probably wouldn't have been able to even staff most of these beds should that surge actually happen. They were struggling enough in the hospitals as it was. New York and California actually called in the Navy, and they had their hospital ships come in and dock for fear of again, surge capacities. So we've been through quite a bit, and there was a ton of activity that took place. I think the good news is that we do have some things to look forward to, or as we are moving forward, but that we have collected a lot of this data that we just went through so that we can analyze it and look back and understand how we might use that to project forward. I think it's safe as we're looking at some of these things to say that there isn't necessarily a solution to pandemic proofing our society or healthcare system. As the saying goes, we don't plan for Easter Sunday. So it just isn't feasible in most situations. But there will always be reactive measures, and one size doesn't necessarily fit all. So when we look at some of these things, what works for a rural health community may not work for a large academic medical center. But we certainly saw innovation and things that people were willing to do to protect the well-being of those that were sick or needed care throughout this whole effort. So big hospitals are not going to necessarily go away. There's still a need for them, but there is going to be a continued push to move to ambulatory care settings. Moving care out of the hospital to these ambulatory settings has been a cost-saving strategy for a while, but also keeps people who don't need to be around the sickest to either protect them or to protect the hospitalized should be kept out of the hospital and have the ability to still receive care. A big push we're seeing in this is in orthopedics and joints. There's a lot of ambulatory surgery centers that are now moving those to ambulatory care settings, but also seeing in planning discussions the look at moving cardiac cath or cath labs out to an ambulatory setting as well. Furthermore, pushing complicated procedures out to an ambulatory setting. Rebound development for organizations recovering from major economic loss will likely take the form of phased or scalable developments to allow them to continue pursuing their strategic initiatives in their markets, but grow their facilities over time. So these are small scale projects initially that can scale up and potentially modular in terms of construction, potentially looking at saving some costs there. Part of these smaller scale or incrementally built facilities may take form in specialized facilities such as birthing centers or ambulatory surgery centers that are looked at in tandem with micro hospitals. This diversification of facilities could be a strategy for some health systems to avoid any one service line or revenue stream from becoming affected entirely because it simply exists in the same building being compromised by a certain patient type being handled, like infectious COVID patients. The front door of the hospital is commonly referred to as the emergency departments, looking at separate entries to try and segregate in times when we have infectious diseases spreading to separate injured versus sick so that those patient populations don't have to mix, and proper screening can be afforded to those patients as well. Less administrative space in hospitals. So we've all seen the benefit of being able to work remotely. I think a lot of hospital staff has as well. So this is very expensive facility space when we talk about cost per square footage. So anytime we can move those folks into a lower cost setting, it's a benefit. Additionally, keeping them out and away from areas where infection may be spreading can also help keep some of those systems that are required to keep hospitals moving afloat, like medical records, billing, customer service, all of those types of things that are also necessary during these times. So as we ended our last slide talking about surge capacity as one of the biggest concerns, some planning discussions or ideas that are beginning to evolve are really surge capacity and adaptability within the hospitals themselves. And so we're seeing that in terms of wanting to or desires to separate or segregate units potentially mechanically, with more air handling units that can be switched to different airflows to separate those units to accommodate either full outside air or different pressurization that may be needed. However, one of the most important ideas that's been around for quite some time that we feel is certainly going to be very important planning benchmark moving forward is the use of acuity adaptable rooms. So within a patient room, and we're only looking at really a private setting, we're considering acuity adaptable beds as rooms that can service a patient in all care settings from critical step down to acute, and without having to move them. So the patient stays in one room. And essentially what that means is the design of the room needs to meet the most stringent requirements to serve a critical care patient. This mindset really follows a trend for needing more critical care beds in hospitals to serve higher acuity patients in an aging population. So taking this direction, coupling it with the pandemic mindset of creating flexibility to surge up ICU capacity, acuity adaptability really finds itself kind of in a sweet spot right now from a patient room development standpoint. So as I noted there, we just need to meet the most stringent requirements other than just staying in one place. So when we look at what those are from a facility guidelines institute, that means we need to meet a minimum of 200 square feet for the room. And that's, it's an important factor. I mean, most of the rooms we're seeing are going to be larger than that. We're not going to be able to meet an ICU room with 200 square feet, but in planning strategies with facilities that are looking at, reducing cost by reducing square footages, that is a 65% required increase in square footage from a standard acute care setting. Clearances around ICU beds are also more demanding, and the amount of infrastructure to head wall will also need to be increased. So these are the things that we see for oxygen, air, vacuum, nurse call, all those types of things that we need to serve the patient are going to need to be incorporated in the patient room so that that patient can flex from a critical care setting to an acuity, a lower acuity setting. A couple other key important factors when we look at maybe not necessarily acuity adaptability, but really honing in on not having to move the patient is the incorporation of dialysis into the room. So in hospitals, this can be something that patients need, but they're transferred to a ward or a room where that service is completed and then moved back to the room. So in this setting within the room, we can really keep patients where they need to be throughout their entire treatment by keeping dialysis in the room. And the last, not the last, but another important factor at the head wall is the patient monitoring and the potential for patient lift. So patient monitoring is really geared towards the settings, and critical care monitoring can really be an expensive equipment cost. So the room can be designed really great, but if it doesn't get outfit with the right types of equipment, it's not going to serve the patients in the correct care setting. When we look at this, we also, again, want to make sure that the rooms are all ADA compliant. It's not a requirement that all rooms do from a code perspective, but in this setting, we want to make sure that we're not having to transfer any special needs patients to a different room. And we're also looking at mobile charting. So a lot of times we'll see the charting station be located on the head wall where it can interfere with new equipment needing to be brought into the room as the acuity of a patient might change. This really allows for that charting to take a different stance in the room to be able to meet with patients, or meet with visitors in the room in a different spot, or potentially leave the room entirely, which can become important in terms of not having to make trips into the room unnecessarily during or with an infectious patient. And with infection patients, making sure that PPE is at the entry of every door. So this is our protective equipment isolation, contact isolation that nursing staff need to put on prior to entering the room. Having that available at the entry of every single room allows those rooms to flex and serve any type of patient they might need to. So this idea of acuity adaptability doesn't just stop with the insides of the room. It needs to also scale out to the entirety of the unit. One of the biggest considerations in allowing a unit to be able to flex up and down is to be able to accommodate different staffing ratios required for the varying acuity levels. Workstations really do need to be able to accommodate staffing levels that can flex from a 1-to-1 ratio for the most critical care patients with direct visual to the room to potentially 1-to-5 ratio of nurse to patients in a lower acuity setting. So the higher acuity settings can also have more specialties that come through the unit and need more workstations. So, these types of touchdown stations outside of the rooms that can be flexible workstations also allow for those types of specialties to come into the unit, not necessarily have to go back to their spot, be able to work outside and collaborate with the caregivers that are responsible for that patient.
Andrew, we have a question that came in
Yeah.
from Sulani. This is the question: the U.S. has adopted single rooms as a standard of care, unusual in many other countries. The additional staffing required in the U.S. is the weak link in the system. Any conversation in the industry on whether we have hurt or adaptability by moving forward from double rooms or rooms which can be double rooms or multi-bed wards?
Yeah, so I think in terms of looking just at the United States from that perspective, it's really been a shift in I think a consumer mindset of healthcare towards the market responsiveness of competition within that to serve patients in a private care setting. Additionally, the private care setting does allow for these separations. Now, when we've gotten to surge capacities, we certainly started to look back at needing to couple people in rooms. So I think the movement away from it's not necessarily a requirement that they be private rooms, but it certainly is becoming more of the standard of care in terms of being market responsive and staying staying with the current trends in terms of delivering the healthcare in the setting of a private room. So I don't know if that answered your question. I know we can't talk back and forth necessarily, but the staffing is going to be an issue that's going to continue to come up in terms of how many people are required to be at the bedside. Now, I think we will talk about that in terms of how technology is starting to help with easing some of those concerns, or our acceptance of using technology to do those things. So we can probably address some of those things as we keep moving forward.
I have a couple more questions. Do you want me to hang on to the end?
No, you can go ahead. Sure,
Okay.
No problem.
From Dana, how do you, let's see, the adaptable rooms, how does that impact square feet and construction costs per bed? That was one of my questions as well, is this all seems very expensive.
Yeah. So I think, right. So I did mention that, from a requirement side of things, it's about 65% bigger just from the requirement side of things. I don't think it actually translates into that. And I don't have the metrics on with me right now, but we certainly could look at that. But in terms of patient room size increasing already from a response to including family in the care, and also just the perception of that space being able to serve a patient properly. The room sizes were already starting to increase just from a response to those types of things, with including family members and the types of equipment and different things within the facility. So it certainly is a exercise that can be done at the beginning of a project to look at comparatively how much more square footage might need to be needed to hone in on saving some of that cost. But from a perspective of investment and longevity of a facility, the acuity adaptability is something that we're always talking about being imperative or a really great thing for facilities to maintain their viability of their rooms, so they don't get locked into something that can become outdated too quickly or they can't use properly.
And
another one, Georgia?
I have another one. Thank you everyone for your questions. Keep coming in. This is from Brooke. If a caregiver needs to gown up in PPE before entering the room, is there a higher risk if they exit the room to disrobe or disrobe before exiting the room?
Yeah, I think Brooke, there's certainly risk on both sides of that, right? So degowning or donning and doffing inside or outside the room poses a risk either to the healthcare worker inside the room or potentially to people outside the room. And so the requirements for that are certainly something the hospitals work through in terms of what the exact procedures are for taking on and off PPE. But I do think that when we'll look at potentially some temporary or expanding the use of what an anteroom might be in some of these situations, could certainly start to be coming back into conversation. I don't know that every single room would want to have that sort of chassis, but there might be the need to start to think about how patient entries could accommodate temporarily setting up something in terms of donning or doffing. And I do talk about that in terms of what some of this actually just coming up in terms of somewhat adaptability in patient rooms might mean for accommodating negative pressure or isolation adaptability. Okay.
Yeah, I
Sure.
was trying to get a good right in between the slides. So yeah.
Yeah. So I'll keep going here. And so that was really starting to look at expanding that adaptability from patient room to where caregivers are working. But in terms of the whole unit, there also is a need to meet the requirements of support spaces. And so this does become that same kind of conversation, I think, Dana, that you asked about, making sure that we're sizing things properly and not oversizing them, and understanding what that impact of cost can be, and really measuring that value benefit for the longevity of a organization on how much space are we giving you that you may not need right now, but as you start to flex up into more ICU beds, could be important to have or accommodate. And so the areas in this floor plan, you'll see at the kind of, I know this project, but we refer to as a knuckle, are really those support spaces that start to serve the critical care nature of these floors, but can also then serve any type of care setting for that. But important things to consider for that are, higher demands in staff in break rooms, more equipment and supply areas, and specialty support services like respiratory therapy, case management, or on-call rooms for physicians, which may need to be quicker to respond to the critical care setting. So the on-call rooms are just really where physicians might sleep so that they're actually on call to go in and serve the patients. Okay, so acuity adaptability, I think, is something that's been discussed quite a bit with the development of nursing units, but I think the COVID really started to look closely at isolation adaptability. And so this was something that a lot of people were scrambling to try and get together. And ASHRAE did release guidance on how negative airflow rooms could be achieved in the safest way possible. But it's important to note that in some of these settings, they may not be really achieving a true negative pressure from that clinical side of things, but really achieving what would be kind of a directional airflow that wouldn't allow contaminants or infectious disease to exit the room. So the initial construction of these rooms also affects it in terms of how tight it is to be able to achieve that negative pressure. And the example that we're showing on the screen here, this is really from ASHRAE to be able to accommodate a negative airflow is to start to begin to activate the facades of these facilities to connect to HEPA filters that could direct exhaust to the exterior. So this can create what, again, what they're calling a directional or negative airflow, helping limit the amount of contaminated air that could leave the room. For larger nursing units, this would be something that, as designers, we start to think about how a facade that typically doesn't have to incorporate something like this, how that can start to activate actually integral care to the patient rooms. So these things are actually pretty noisy. So as we start to think too, is that something that we're going to have to accommodate in the room if there's a purposeful spot that it could also be placed in, so that it doesn't disrupt the quality of care that the patients are receiving. And so, Brooke, this is something we've started to think about, or at least pay some attention to with the entry of rooms. Again, being mindful of the requirements of square footage, putting additional entry or ante rooms into these spaces can be costly. It may not be always necessary, but could there be a potential to look at these spaces to set this up temporarily? I think is a possibility. And so this could be something where, by simply organizing the entry to a patient room in a way, making sure patients, this is also specific to, I should mention that this is a inboard patient room, which actually helps the throw to the patient room become a little bit smaller, which may help set some of that up here with access to the restroom. But is this, this is looking at potentially being able to accommodate something like that, Brooke, where the patient can leave the room, take their gear off and then go into the corridor, so that they're effectively no longer exposed to the patient, and also not exposing people in the corridor as much as they might need to. So I guess, as they say, necessity is the mother of innovation. So picture on the right is an actual product in development that's trademarked, the Highline, which is being developed at Cleveland Clinic. This is used to keep IV tubes off the floor when patients are ambulatory, but in this setting, it's actually used to hang extension tubes from IV poles into the patient room. This practice was established during COVID to help reduce the number of trips that staff had to take into the patient room, preserving PPE and protecting staff from unnecessarily exposing themselves to COVID. So further development of this is taking place, and may start to take a role in how intentional integration of IV tubing being able to leave the room, with integration of connections into the head wall, or potentially door hardware or wall pass-throughs that would allow tubing to, actually do something intentional, not just go through the crack in a door, but move things outside the patient room so that staff don't have to go in unnecessarily to treat those patients. It would need to be also more intentional in the corridor than the top picture, not advocating for that, but just as a result of bringing all that equipment so that we don't have to go in and into the room with infectious patients. So staff burnout was huge, as I've mentioned before, and hospitals had to deal with staffing shortages, as well as extremely intense and stressful environments, which brought to the forefront really how important it is to consider holistically the spaces we design to not only accommodate the best possible environments for patients, but also for the caregivers. So one space in particular that became a particular interest with one instance was the staff break room. In older models, I think this may have been more traditionally placed in a more expedient location in the facility without much thought. More recently, we've started to transition the idea of providing caregivers a space for respite, where they could find rest and relief with higher regard to where these spaces were intentionally located, where staff would benefit from a positive environment that included natural light and a more comfortable setting. But during the pandemic, this was taken even to a further level of something that might be considered recharge. And so this is a specific name of something that a group called Studio Elsewhere did, and called them recharge rooms. They did it in collaboration with Mount Sinai, where repurposed triage tents were purposely separated from the chaos and provided an immersive environment through the use of technology, sound, smell, and texture that really were drawing on the biophilic design principles that reestablished people's connection to nature. this is really one example, but they were seeing reports of about 60% in self-reported decrease in stress levels. So this became something I would encourage you. This is a link. I don't know if you all have access to this presentation, but the link here is a link to the podcast. I would encourage you to listen to it. It's really great information in terms of the responsiveness and appreciativeness that the staff had for these spaces. So as telehealth became a lot more prevalent during COVID, so I think is the response using technology to be able to handle staffing shortages. So in response to that first question, the use of tele-ICU is something I think that when considering how do we deal with these surges could be something that becomes a lot more prevalent. Tele-ICU has been increasing since 2003, where approximately 9% of beds were covered by this type of setting. And it's now estimated that approximately 20% of beds at some point are covered in a remote care setting for ICU patients. This, again, is of particular interest when infection is at the highest or staffing shortages can be more crucial. So centralized teams centralized monitoring teams offsite are paired with on-team sites. And a 2004 study really has found that, or a study with information back to 2004, has found that using this type of care setting with remote ICU and on-staff site led to a 23% reduction in mortality and 43% reduction in length of stay, increasing throughput. So all of those things really beneficial in terms of bed count and then also life-saving measures. Additionally, because of the technological advances and making more and more electronic medical records with recording these types of things, integration of AI is being able to analyze this data and be able to respond to less noticeable things that staff may be able to see on site and notify caregivers of a response as needed. So Philips EICU is really emerging kind of as a front runner in the market, and really just as last July landed a $100 million deal with the VA to cover their ICU beds in a tele-ICU setting. So it is something I think that's going to continue to increase and be more prevalent. I'm going to try to hurry up here. So screening patients prior to entering a building became the norm for healthcare settings during the pandemic. In an ambulatory setting, there wasn't always the best place for this. It may have been a vestibule or right after you enter the building, but the purpose of the screening was to keep sick people out of the space. So in the example shown here, in the example shown here, the intention of this space was to create a sense of arrival where patients entering the building could actually decompress or be greeted. This elongated entry area actually made entering the building sorry, you guys aren't seeing that. That's the elongated entry area there. That actually made entering the building an experience, an intentional experience, but also led to a couple of flexible uses, and in the case of COVID could really be used for I keep losing my ability to click, screening patients or taking them to a dedicated screening point where they could then enter the building or leave because they actually are showing signs of being sick or ill. And as an extension of the intake process, registration can be a place where people potentially end up waiting in line or sitting close proximity to each other. So again, in the same facility, we looked at keeping registration in as mobile a setting as possible, with the intention that these registration pods could be taken down or set up if needed to rearrange more in line with the conversation. As technology advances, they could change their registration setting, but again, has also shown that flexible type of space can account for now increased seating or social distance seating in a waiting room. So within the actual ambulatory clinic modules, these are the exam room configurations we're talking about. The segregated core model presents a lot of benefits when trying to limit unnecessary interactions between patients and staff. This exam room model here on the right looks at having two entries into the exam room, one from a patient access corridor and one from a staff work area. Because the staff don't use the patient corridor to access the exam room, this essentially creates a model where the only interaction of the clinical staff and patients could occur in the exam room. So if this model is paired with technology that would alert patients when their exam room is ready, a patient could effectively arrive at the facility ahead of their exam, wait to be notified that their exam room is ready via text message or phone while waiting in the car. That same text message could tell them which exam room they're in, and they could themselves self-room and then see their care provider in that setting. So effectively, you could remove any type of interaction with the use of technology in this type of setting, unnecessarily exposing people to risk of those that might be sick. Okay, so infection prevention is not a new discussion in healthcare facilities, but again, was elevated with COVID. The COVID's really understood primarily transmit person to person through air and a lesser degree on surfaces, but it still does have the ability to retain its infectious qualities on surfaces. So high touch surfaces remained an area of focus for cleaning and disinfection throughout the pandemic. The important part that I guess I want to touch on here is that there is a distinction between being antimicrobial and actually having effectiveness of inactivating viruses. So studies have been done on the materials that are used in antimicrobial materials, but it's important when looking at these things that manufacturers actually provide documentation that it has been tested to actually inactivate viruses. So NCBI studies have looked at 3 categories of materials. First one being metal or inorganic compounds, which are copper, zinc, or silver, which are commonly used in antimicrobial surfaces. Polymeric or antiviral coatings used with disinfectants or chemicals, which really some chemical applications have been discouraged in healthcare facilities just because they can be contributing to factors of superbugs and different things of that nature. And then some emerging technologies of nanostructuring surfaces, which promotes self-cleaning qualities to surfaces. So in addition to high performing materials, with surfaces being able to be cleaned, actually not touching the surfaces would be great too. So sensor activated soaps, hand sanitizer, doors, a lot of those things are really deployed in hospitals, but starting to look at where we can extend that to things like elevators with sensors or potentially apps. Now, the apps may be more prevalent in high-rise situations than hospitals just because of the continued use of them, but still, anytime we can stop touching a surface may be something we start to see deployed more in healthcare facilities.
Andrew,
yeah,
I have a comment, but I think it's a good point. When you're looking at even telehealth or tele-ICU or this ability not to cross-contaminate with employees versus patients, how the lack of human contact has to do with patient care and how maybe the how it will impact the reimbursement rates in the long term.
absolutely. Yeah, I think I should have mentioned, I did have written down, I'm not advocating necessarily for like a completely humanless interaction in healthcare facility. I think it's an extreme that maybe those clinic modules may be able to accommodate. We certainly want the patient experience to be human and interact with folks. But as we'll look here a few slides ahead, I think there's a stat that I have about the number of physicians that believe telehealth is going to be required. But in order to do that, reimbursement rates also need to start to match what they were for seeing patients in person in order to continue to support that effort. So certainly it's going to be important that policy align with how care is going to be delivered to continue to push that forward. I think in all of these things. Is that good to go? Keep going, Georgia. I'm probably running.
Yeah, no, I think that was good. No, you're fine.
Sorry.
I think this is a great presentation. So if we go over, I'm not worried about it. So just keep going.
Right. So indoor air quality, again, something we're always dealing with, but became much more prevalent with COVID. We're considering kind of 5 factors together that really creates your entire indoor air quality approach, but high filtration, something that healthcare facilities are using. But if you're looking to increase that higher filtration, we need to make sure that the pressurization can be maintained. Humidification does limit the ability for viruses to carry in air. Excuse me. Did I lose it? So sorry. So humidification is something that healthcare facilities use a lot of, but does help reduce the transmission of viruses. Increased ventilation or outside air was something that a lot of facilities looked at in terms of trying to switch to 100% outside air in some situations to be able to get that potentially contaminated air out of the building. Ultraviolet lights in AHUs have been used quite a bit, and then newer technology that we're looking at, needlepoint bipolar ionization. Really, those two compared to each other, the ultraviolet and the NPBI are looking at how we can treat air or things within the air. So the ultraviolet can inactivate viruses within the shine path. Needlepoint bipolar ionization can actually help with charged particles in the air, treat air that's actually in the space. So when you consider these two next to each other, ultraviolet really requires things to happen within the shine, and moving air is a little bit too fast for that to be effective. So needlepoint bipolar ionization has been looked at in terms of being able to actually look at treating air by having charged particles either collect with particulates in the air to make them larger so they can be filtered out, or start to inactivate them. So here's that telehealth slide again about where we're headed with things, and really looking at telehealth, not just about being in front of a video screen, but also expanding to things like asynchronous visits where we're uploading videos or leaving messages for physicians, or remote patient monitoring. So I found the picture of one of the Jonas brothers there intriguing as he promotes his Dexcom continuous glucose monitoring that can also be reported to his physician for those types of things. So these wearables are going to expand just beyond our Apple Watches and different things like that into actually being things that can be effectively providing care. So these two stats on the left were, I think, what we're talking about in terms of 70% of doctors believe reimbursement and policy change is required, and that same 70% receive that telemedicine is going to be required moving forward, just in terms of being able to reach the patients that they serve. Okay, getting caught up here. So the pandemic really did provide a launching pad for increased acute care services at home, making healthcare home more consumer-based. So a William Blair survey reported that 81% of physicians responsible for discharge planning actually preferred to send their patients to a home healthcare agency. Still, even with the pandemic, less than 1% of hospitals are enacting hospital at home care. CMS did announce acute hospital care at home programs, and is expected to increase governmental funding here. Health organizations like Mayo Clinic and ProMedica are teaming with a company called Medically Home that provides really acute care within their house. So this is a team of providers that will visit them in their house and virtually. They can provide infusion and IV therapies at home. They bring mobile imaging, X-ray, and ultrasound there as well, and can also come and do lab tests. So this is something where if people can receive care, the benefit is that the providers are actually seeing the people in their care setting in their life, so that this feels more a part of who they are, not just something to treat an episode, but something that they can maintain themselves as well. I just wanted to quickly look forward on a few things that touch on maybe not immediate things or reactions or tangible things that we can necessarily put our finger on as outcomes of the pandemic, but are important to hold in front of us as we continue looking ahead. So as discussed earlier, there's been a lot of delayed care and human impact that the virus has had on us, and it's really hard to quantify. But the chart on the right was developed by Dr. Victor Sang, who is trying to visualize what some of these futures might look like as a result of the pandemic. So on this chart, we're still in the first wave, dealing with the initial mortality of the onset of COVID. The second wave is really looking at readmission or COVID-related conditions as a result of having COVID that have impacted so many people, and as well as delayed care. So this, you can see the second wave really does, or the first wave tails, I should say, with the second wave really does start to look at, are we potentially in another surge capacity issue where that acuity adaptability could really start to come back into play. Third wave is really delay in chronic care conditions. So things that didn't happen now because people were delaying care that could have been avoided had they had preventative measures. The fourth wave here is really what starts to cast the shadow in a sense that I think will have a really lasting impact as with COVID on our mental health. It's shown an immediate effect during the pandemic. However, most are focused on really what that's going to mean long-term for our society as people continue to cope with the anxiety and mental anguish of the pandemic here. So I think mental health is something that's certainly started to increase in the healthcare industry in terms of awareness, but it's going to be something I think we continue to deal with as really what they're calling the shadow health crisis as an outcome of this pandemic. So some of the highest impacted parts of our community by COVID were those that were in underserved areas. And really healthcare is holistic. So it's beyond just receiving care for an ailment, sickness, or injury. It really does need to reach into the quality of life of the individuals on multiple levels. But when it doesn't, it can greatly affect the holistic health of an individual. So social determinants of health are recognized by the CDC and healthcare industry that literally look at 5 main conditions of where people live, learn, work, and play that have really a wide range of impact on health risk and outcomes. So the biggest impact COVID had on determinants of health was jobs. So economic instability caused a major increase in anxiety and access to health coverage. Some major determinants of health that systems have been teaming up and partnering with previously are transportation, access to quality foods in underserved communities. And while these remain extremely important, the rise in use of technology that we've been talking about with telehealth, a huge determinant of health is really going to be access to proper data or broadband connections. And this can really start to reach to rural communities that are already having issues with transportation or long drives to see physicians. If they can have access to that type of immediate connection to physicians, this can really start to close a gap in one of the determinants of health of access to that care. So reducing and addressing these categories, these determinants of health as we move forward is certainly a key issue in building resiliency in our broader healthcare system. So I think it's important to just quickly look at our response as a society as well. We can always work to make systems, operations, facilities more resilient to handle emergencies, but I think sometimes that we overlook how we can make ourselves more resilient. We responded a lot by wearing masks, maybe somewhat hesitantly at first, but ultimately the response has been widely accepted. But as we move forward, I think it's important to ask ourselves if we can look to public health initiatives around exercise, mental health, cardiovascular disease, diabetes. The awareness of these helps make us more pandemic resilient in and of ourselves. So it's really taking a good look at ourselves and seeing how we can make ourselves more resilient by listening to those leaders in healthcare positions and starting to respond. And I know I'm optimistic on this front that we can act in these ways because I've seen it. Like many of us, I've been in meetings with kids crawling over coworkers or my kids yelling in the background. I had to come into the office today to make sure I wouldn't get tapped on the shoulder for something while talking to you all. And some of us became homeschoolers on the fly. So while these may not be as intense changes in our lives as maybe some of the healthcare workers experienced or other frontline workers, I think it does show that we can be extremely resilient when we need to be. And I'm really optimistic about moving forward. So thank you.
Well, Andrew, that was incredible. I actually have a ton of questions. It was such a good presentation, and you're such a resource. But I guess out of time, I won't keep everyone on listening to my questions. Yeah, this was just incredible. So thank you so much, Andrew. And I know Stephanie has a couple things she wanted to say.
Yeah, I'll go ahead and share my screen.
Well, I guess we could do a last call for questions if you
Yeah,
have.
absolutely. I can talk and do a last call for questions, and we can answer. Oh, that's the wrong one. Oh, no, that's the right one.
So maybe if you guys have anything, try and get them in the chat or the Q&A, and we'll let Stephanie finish up, and then we can address anything else.
Yeah, thanks, Georgia. And thank you, Andrew. That was terrific, just to see in the horizon where we think healthcare will be going. I'm going to do a quick little plug for the rest of Architecture Month. And because we do have another 4 sessions, actually all busy next week, Monday through Thursday. So do sign up at aia.org/Spokane. But we start on Monday with an event, a webinar put on by BEC Spokane, a new paradigm for building enclosure delivery, performance, and durability. And then Tuesday, we follow up with the Pine Creek Community Restoration, recovering from the Malden fire. We have a whole community of panelists that will bring in different perspectives and what they need from architects like all of you. So please do sign up because there is help needed. It's not an urgent need. It's one of those things that going forward as they rebuild, there is that need. So please plan to attend that. And then we kind of finish it off with a 2-part program. We have the Riverfront Park Ice Age Flood Playground. Part 1, that's a virtual presentation on Wednesday during the lunch hour. And then we follow up with a actual in-person tour, our first in-person tour since COVID started, a tour of the playground presented by IIDA and ASLA. This particular tour right now is limited to members of AIA, IIDA, and ASLA. If we don't get the 40 people, we'll go ahead and open up to everyone else. This will be following COVID guidelines. We will be splitting into small groups. Yeah, so we'll make sure that people stay safe with that. So please plan to sign up. And with that, I'm going to go ahead and announce our winner for the raffle at the Spokane restaurant scene. It's a $50 gift card to Baracho Tacos, River City Brewing, Fast Eddie's, Boombox Pizza, and Red Wheel, and it goes to Jordan only. So I'll go ahead and email you, Jordan, and put you in touch with the CSI representative, Georgia Spencer, and we'll make sure and get that gift card to you. And continue to sign up, and we'll look forward to seeing you at future webinars next week. Did we get any more questions?
No, we just got, Andrew, you just got a lot of compliments, many. So.
Well, I appreciate all the support, everyone. Thank you so much.
So, and I'll also say one more thing. I know we have a lot of people from outside the Spokane area, which is terrific. That's what, I guess one of the benefits of COVID is having these webinars expand our geographic reach. So you're welcome to join any of these sessions as well going forward if you find interest and need some AIA credits, because those have all been approved. So we'll look forward to having you join us if that works into your schedules. So with that, if there's nothing else, I guess we can go ahead and adjourn and wish everybody a great rest of the day and week, and we'll catch you all next week.
Thank you.
Thank you.
Thank you.
Bye.
Bye-bye.